We must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Hi everyone, my name is Stephanie Wyrock and welcome to the Healthcare Education Transformation Podcast. I'm joined of course by my co-host, Brandon Poen. We are live at APTA Next here in Orlando, Florida, and we are joined by a very special guest. Scott Euype is here. Scott, can you tell us a little bit about yourself and kind of what led you to where you are today as a clinical education expert?
Well, I've been practicing 30 plus years, and I started off as a regular clinician working in neuro care, basically, and I always had a passion for teaching students, so I had, within my first year, I started having students, and as my career progressed into more orthopedic world, it just kept going with wanting to take a student every year. And one benefit of getting a board certification, people sometimes don't think a board certification is important, it gave me an open door to start teaching part-time at a university, Cleveland State University, where I live close by. And that experience of teaching academically got me more experience with the students and then able to do more clinical, kind of short-term clinicals. We do some pro bono care in the Cleveland area, and the students go there as well. And I've been blessed to be able to work in the pro bono clinic with students and kind of give them the idea of giving back to the community. My role has progressed now to where I work at the Cleveland Clinic, where it's a multidisciplinary health system, and I oversee the student education for all disciplines, OT, speech, athletic training, as well as PT, PT assistants, of course, as well. But it's been just a journey of like doing things, getting experience of doing it as far as doing clinical education with students, and then progressing that to what's best practice and helping other CIs become better, mentoring them, and then from there getting the overseer to kind of now communicate with other site coordinators and help them with their mentoring of other CIs. So that's where I'm at now.
That's really cool. In case our viewers aren't aware, Scott just ended his term as a nominating committee member for the American Physical Therapy Association. So he is done with that, and now I'm assuming that are you going to be taking on any new roles at all at your institution? No new roles, Stephanie. I'm going to kind of stay pat with what I'm doing. Maybe I'll have more time now to finish some projects that are on the Post-it list on my desk, pile of Post-its. They're there, and I haven't had time to get to them, but yes. One idea actually we're working on, it's like a lot of health systems, we're trying to do clinical pathways and using the clinical guidelines, the clinical practice guidelines, set up pathways for our staff to kind of be more competent in their practice and working at the highest level. But one question we haven't done with it, we do the education piece well, but we're not monitoring that change of practice. Does it change outcomes? So on my kind of list to do is like that next step where, okay, we taught the staff how to practice. Are they changing their practice, number one? And then with that practice change, are there different outcomes? Do you feel like with students coming into your practice and being around all these clinicians, do you feel like that has impacted any way on how any of your clinicians practice?
If they're a good clinical instructor, yes, because students teach us. Students know the information. They know how to obtain the information probably better than we do with experience. So yes, I think students teach us all the time. We have a pretty much a standard, if you will, that students are going to at least present one formal professional in service, not just a handout. I want them to do a professional portfolio, but part of that, they're teaching us then, a clinical role, if you will, to our staff.
No, I love it. And I love how, specifically with your role, I think this is the first time on the show we've ever had someone who's really been involved with true healthcare clinical education, like from all these other disciplines. We've mostly had PT on for that realm.
Okay,
so
great, yeah.
I've got to ask, just because, to kind of open the doors to kind of what you see all these different professions kind of under your hat. And my question is, what are some of the biggest limitations or issues that you are seeing or experiencing kind of regarding healthcare clinical education?
Well, the variability. And PT, as you know, probably if you've been talking to other people with clinical education, there's so much variability, the length of the clinical, what placement should they have, what's the sweet spot as far as the number of weeks that should be there. And that's just PT. OT is standard. They pretty much do their 12-week clinicals. They do 12 weeks, level 1, level 2. And then they may have an elective. I know the doctorate OT is going to have a capstone project on top of that clinical education piece, which is very intriguing because I think this capstone is a project then that helps the site. And I think that's going to attract the concept of, if I take you on as a student, what are you giving us? The in-service is nice, but maybe a project of something of substance that will help the site. That may allow the site to go, maybe we'll take more students. So OT is doing that, that's different. And in speech therapy, it's totally different because they do an internship, which I know in the PT world, there's this internship concept that's not accepted overall, but it's being one of the options thrown out for clinical education. Speech does that, and it's very successful for them. Athletic training does an elective internship. Not all the programs have an internship, but some do. I think that's growing now. They're going to be a master's level training. So understanding each discipline where they're at and kind of putting it together. We have a team of each leader in, I call it our clinical education leadership team, and each discipline is represented, and we try to hash out the best practice between our disciplines to make some uniformity. We have a unified student handbook. So all disciplines are represented in that, so when a student comes on to our site, or one of the sites, they know what they're going to get. And all disciplines are there, so the student can even know what specialty they may want to observe or be involved in when we talk about interprofessional education. I think we're doing that. It could be better because I want to have more true, student being with multiple other students from other disciplines. We're not doing that quite yet, but at least we have the disciplines represented together with the students practicing.
Yeah, and one thing, of course, that, as anytime we're doing something new to try to see how we're changing, pushing the needle forward, we also want to be tracking our progress objectively. And
right.
I guess with that, my first question is, based on what you know from these other healthcare providers, not just PT, but in terms of their clinical education, do we have any outcomes or measures on how successful we are doing with those changes? So I guess that's my first question.
Yeah, Brandon, I just my involvement with the APTA, with the education, the Academy, of Education, ACAPT, and I was the APTA with the partnership, I think, is trying to do that, but we don't really have good clinical education research. I think if you heard Dr. Hack this morning, Dr. McMillan, she expressed that we need to have educational research. It's valid to kind of study that. Right now it's anecdotal. And that's why when I said what's the sweet spot as far as the length of the clinical, it's anecdotal, it's level 5 evidence, but the idea I think of 12 weeks seems to fit. 8 weeks is just enough to get the observation, learn how you get on the EMR. But when I see a 12-week or 16-week clinical, it seems like the students are now really practicing. They're starting to understand the process that we have this in the system, but then they can start getting better care.
Oh, absolutely. I think for me, just even personally, my school rotations were the first one was 6 weeks and the remainder of them were 8 weeks.
Okay.
And I can see, for me, and this is just how it was personally, is that I felt like at the end, finally I was getting comfortable on my own, week 7, week 8.
Yeah.
That's when you go. But I can
there's
see...
not an outcome to look at that to say, it's 8 weeks isn't as good as 12 weeks.
I agree.
Yeah.
No, I agree. But then it's also are the shorter, I could see the shorter rotations being good if it's a rotation that you perhaps don't want to pursue.
Right.
And then would a longer one perhaps be ideal for one that, I want to go into orthopedics, so I'm going to choose a I'm not going to go to the hospital, so I might choose the 6-week one for my acute care, and I might choose my 12-week one, just hypothetical for.
Well, the Oxford debates last year, that was our debate. Can we have a specialist? Because if you're really interested in outpatient orthopedics, let's say, and we say, no, you gotta have acute care, you gotta have neuro, I understand you need to have exposure to it, but
Absolutely.
I want to be an expert. When I graduate entry level, I need to probably have more clinical experience in that specialty area. We lost the debate though, so I'm not sure.
That was a great
That was
debate.
great.
Scott, we've been talking a little bit about PT clinical education. Is there any research going on in the OT and speech world on clinical education there? You said that OT has standardized their clinical education. Has that come out of research, or is that also anecdotal?
I think it's anecdotal. It's what they've done, and it seems like it works for them. I don't know of any specific research looking at outcomes. And the other piece might be, what are outcomes? What successful outcomes for a student going through a clinical education program? I'm not sure we're aware of that. There's a big talk now about competence. What's the competent student? And let's say we determine some competency skills in a 12-week clinical, but you pass those competencies by 8 weeks. What are we going to do? Are we going to let you finish then and save time and money, maybe, because you're paying for those clinical education experiences? Or do we give you more advanced training because you met your competency here? Let's give you a little bit extra to give you better outcomes, but we're not aware of what those outcomes are really.
I recently had a long discussion on competency-based curriculum for clinical education with Jodie Frost. And she was an expert on this, and she was explaining to me that this is something that is starting to be implemented by medicine and in vet school. This is what they do in vet school. And she said this is something that really stuck out to me in my conversation with her is, we could learn a lot from veterinarians, and we don't interact with them enough, which is an interesting statement because in the House of Delegates, which is the policy-making body of the American Physical Therapy Association, we just passed a motion to encourage physical therapists to interact more with veterinarians. So I think that kind of has a dual usage, both with animal rehabilitation, but perhaps even with clinical education.
Right, and I mentioned the Education Leadership Partnership, that's the ELP. APT is looking more externally, and so maybe that will help us. And I haven't heard Veterinarian Association come up, but that may be a group we need to look at to study what their outcomes are with clinical education.
Well, I think that's important, and we've heard it's been echoed throughout this conference and throughout House of Delegates that we need to be more externally focused. We can't be so internally focused in our profession. We know who we are now. We have an identity. We have a mission. We have a vision. We have values. So now it's time to try to be at the forefront of changing healthcare policy, and hopefully part of that is clinical education to produce people who are more effective in that direction.
Right, we want more efficient graduates coming out so they can move that needle forward right away.
Yeah.
You guys recently, you're working and you can't not see patients and have good outcomes, or your employer's going to say, hey, what's going on?
Yeah.
So we want to train you in your clinicals to be ready for that day one.
Absolutely. So kind of taking it to another level. So say, for example, that someone wants to get more involved in managing clinical education, like perhaps like in your role. What are some of the, could you kind of give us kind of like an overall snapshot of what that experience entails to kind of give some perspective on what are some of the barriers or some of the things that you go through to really work on implementing that, to really make these changes happen?
Well, some of the barriers to make things changes are the academic institutions have been doing something for a while, and change is not easy in the institution. And that's not a blame on anybody, it's just it's hard to change curriculum. So for us to kind of sit back and go, we want 12-week clinicals, now I guess I could sit down, put my foot down and say, we won't take your students to go to 12-week clinical, but then I feel that's unjustified because I can't prove that those 12 weeks are, that's a barrier.
There's no evidence.
Yeah, exactly. So the barrier is lack of really hard science to support that. And it's hard for schools to change as well as it's for us to change. But the conversation's happening. The education summit that we had in 2014 had multidisciplines, and we had all kinds of experts across the country represent from ACAPT and APTA and the Academy of Education. And it was a good concept, A lot of talking, but nothing really objective has come from it yet. But there are some research projects in the works that may give us some of that data that we'll be able to use to improve that.
So Scott, you had mentioned that, how do you know if a student's come out competent? And obviously we don't necessarily have a lot of the data to back that up, but I am interested in your perspective on the importance of mentorship for clinical education and what your perspective is on mentorship. Are we doing a good job as physical therapists in mentoring our students and helping them come out competently? Or is that something that you've seen that isn't really as strong as it should be?
Well, Stephanie, the clinical education credentialing program, credentialing program, CICP, I use these acronyms, I'm sorry. But they have one of the sections talks about mentorship for the student. And this actually came from the student assembly. I forget which year, I want to say 2002. But the student assembly brought forth the need for mentorship. And why I'm bringing this forward, when I teach the CICP course, I find many of the CIs are not APTA members. So I think one thing I need to encourage our CIs, we need to encourage all PTs to be APTA members, but the CIs have a lot of resources from being in the APTA. And to mentor, I think that professionalism is one piece I think we are lacking there. So when the student comes out and they see their CI not being an APTA member, that's what the CI or the student thinks. They think, well, it must not be a big deal. So I'm always encouraging CIs to be members of the APTA. That's positive professional mentorship. So they can say, yeah, we're teaching how to be a PT, but part of being a PT is going to APTA and going to professional meetings, going out in the community to do pro bono work. And I don't think we're really teaching that. If we're not a member, I think some of our CIs are missing that piece. If that makes sense.
We just got out of the Catherine Worthingham Fellow lecture, and they talked a lot about how we as physical therapists need to take more of an active role in public health and in pro bono services. And it's true. You sometimes come into a clinical, the clinician works 7 to 6, goes home, hangs out with their family, which is great, but you don't see a lot of, the student might not see them do a lot of outside activity that's promoting professional advancement, professional development, or just being involved in the community. So I really appreciate that you mentioned that. How do we compare to OT and speech as far as mentorship goes?
I think they're right along with us. I think, and I think I would throw medicine in there too. I'm thinking from what I've seen, again, it's just reading kind of superficially that all our professions in healthcare are struggling with this concept. So we're all trying to do it, but again, can we collaborate together to make it easier to obtain? I think so. APTA does have resources though in the Learning Center on mentoring. It's more for residencies and fellowships, but I've used some of that with our CIs and taken some pieces from that to help our CIs maybe learn what is mentoring.
Yeah, so just because I know there's a fair amount of our audience that are people, including students and clinicians, that perhaps do not look to APTA for these kinds of resources like you had said before and how that is. What would you say, like if you had a sell point to sell that to maybe some of those skeptical clinicians to really get them on board, what is unique about those resources that can really help propel that change forward?
The one resource that I give every new PT when they're concerned to be a student is self-assessment of clinical instructor. It's on the APTA education site again. He's saying Academy wrong. Academy of Physical Therapy Education. We're going to have a problem with all our sections and academies.
I know.
As far as branding, I know everyone's changing. But the self-assessment on clinical instructor, I think is a good tool. I just download the PDF and I give it out. You don't have to be an APTA member. I mean, I'm an APTA member. I use it as a resource for even a non-member because I want them to kind of self-reflect on themselves before they take on a student to see what things they may need. Based on how they scored, and we can maybe help educate them on those deficiencies, or maybe give them, I have a lot of the newer PTs work with shadows students, and kind of just that communication is one thing, and then mentor that process as far as how did that go, what things did you feel weak on, and can we help you with that to improve that, even just a shadow student, right? Because it's marking their profession, and then going forward with maybe helping the students when a CI is on vacation one day. So hey, maybe can you oversee the student? I do that immediately. I don't think you have to wait a year to be a CI formally, maybe, but that process throughout that year is training the young professional to be ready to be a clinical instructor because they want it. And so I'm going to give the experience with the competency along with that.
Yeah.
I would also say that, the APTA credentialing course is a very valuable tool because a lot of clinical instructors maybe get students that are subpar and they don't really know how to handle that conflict. And I think that course really does a great job at giving you the tools so that if you are faced with that situation, you can handle it professionally and in a way that is going to help that student not necessarily feel bad about themselves and feel like a failure, but so that they are empowered to be better and to change. And that is such a hard thing to do as a clinical instructor, especially as
and it helps with objective goal setting. There's a lot of powerful tools in that class. And that is multidisciplinary. A lot of people may not know that. PT, it's driven for PT. There is actually a credentialing process that we go through self-assessments, or actually assessment centers for specific skills in clinical education, but it's open to OTs, it's open to speech, and open to athletic training. Occupational therapy does have their own credentialing class now. It's very challenging. There's barriers of getting new classes, though, because you have to have a clinician and an academic person, which I think is a nice model to teach the class, but it's very selective in who those instructors are, and I've tried to get some of our staff to be an instructor, and it's not easy to...
For the OT one?
Yes, for the OT one. The PT is, if you're interested in being a trainer, they have actually courses to train you to be a trainer in the CICP. It's a great way to get involved in teaching, because you do take the video of yourself teaching, and they critique you in a constructive way, and you learn some skill sets of how to be a better instructor.
Yeah, no, absolutely. And I think it's interesting because going back to kind of overall, we talked a lot about interdisciplinary and kind of different views from other professions on how to improve clinical education. Now I do want to take one little brief narrow focus on PT. So based on from what you see from all these different professions and stuff and what they're doing, what are some things that you think we as PTs need to start implementing? Now I guess, like we talked about before, realizing this is anecdotal, there's not a lot of hard evidence yet, but if we don't go and try stuff and then start to measure it, we won't know. So I guess my question to you is, what are some things that PTs should start incorporating, or what are some things we should try out that perhaps other professions are doing to help move the needle?
Well, I think this idea, the Doctor of OT program, doing the capstone, where it's a significant project. It's not just like doing like I said earlier, it's not just an in-service. It may be something where they go to the site and we need some help in developing actually I was talking to someone from Johns Hopkins. They're having their OT student come in and actually help design maybe a new satellite with the business plan. So that's something I think we could do as PTs as well, because that's something in management, but maybe that PT wants to start their own private practice after they graduate. How would you set up a business plan to open up your own office? That would be a great training, but it will also help that site, because it's helping them maybe develop a new site and expand their practice.
Yeah, and I think it's interesting, yesterday, even hearing Stephanie and us talking in a group about clinical education and stuff, and what are some things, so rather than just also focusing on clinician, just being a clinician, we got to look at what does it actually mean. So that means we have to know the business, we have to know knowing all these things. And I know some people, when they're in clinical education, do not get exposure to that, and then when they go into the real world, it's kind of a slap in the face. So I guess, how can we best solve, how do we integrate all these pieces so a student on their clinical rotations can get this exposure, so they don't feel like they're kind of thrown to the wolves when they first start out?
Right. I think we need to probably go to the direction of asking the students a little bit more what their needs are. Here's what I mean by this. Our values, your self-assessment. We score ourselves from 0 to 5. Maybe someone really wants to do advocacy. So maybe we help that student, even in their clinical internship, work on advocacy and how to do it. That's kind of different. Or maybe they want to do more social pro bono work, so maybe we can help that student have opportunities to do that. So that's going to take work on the site's part to open up their viewpoints, and it's also going to take the school to kind of say, yeah, we're open to that concept because it's education. I think we can do things in engineering, innovation, concepts. We're not typically having clinical experience in that, but I think we can open ourselves up to that. And then going to community centers, really teaching the community how to do things differently. We're experts in movement. Why aren't we helping to teach that. And I think that's the idea, right? Competency and our vision is to change society, to help the society. How are we doing it with clinical education? Maybe we can use these concepts of different models, because we're not traditionally doing that in clinical education, but allowing that to be a part of it. We may add on to school, and I don't know. But
We had alluded to the year-long internship that is in some programs now in PT. What are your thoughts on that model, and how do you think what you just talked about, this more well-rounded physical therapist versus just the clinician, but the clinician with a societal impact, how do you think that could be integrated into that model?
Well, I think, I'll be honest, the internships is concern me because I'm not sure how we're going to fit into my system where I work, and the idea of paying a student is stipend. I think we could do it, and this concept came up just this morning. I was in a meeting about society needs. I'm like, how could we do that? Are we able to do that? Financially, would we be able to do that? I think the internship would allow that because it would give us more time with the student, right? But it's still really a change in mindset and paradigm that to make that happen, I would have to get some buy-in from administration, even let us do it as PTs.
Right.
So let alone, maybe allowing the student to do it would be a bigger buy-in because we can allow the student have the opportunity. It's not taking away our cost per se. It may expand practice and get us into the society better.
Yeah, it seems like we're at this point where we have of course, this is probably most of things in life, but you're balancing cost versus making things broad. So are we producing a well-rounded clinician that's not just focused on their clinical work, but they're focused on improving the health of the community, they're focused on advocacy, they're focused on making sure that children in the community have wheelchairs, all these different aspects. And it seems to me that a student would have more time because now, like you said, I guess I would say anecdotal evidence says that it takes about 8 weeks or more for a student to feel comfortable in that clinical setting to really start improving their skill set. Well, perhaps if somebody's in a year-long clinical, they're almost an employee, so now they have time to actually get involved in that. So it seems like there's
probably dedicating some time to that to allow them to have that.
It seems like it's definitely a big balance between those two factors.
Right. So I was against the internship, but my mind's kind of opened up a little bit more to it. I just got to get my hands around how I could fit that into a program, and that's where I think again. Clinical education has to partner with the academic institutions to come up with these ideas together. And that communication is happening. It's going to happen because people are talking. As long as we keep talking and listening to each other.
No, it's true. And, so I'm going to take a totally random question here, Scott, in terms of what are some of the biggest resources or most helpful resources, other than you had mentioned before a few from ETA and such to help with just clinical education, but even in general regarding clinical education or even just education in general, what have some of been the biggest and most influential, helpful resources that you have found that you'd recommend to someone?
Well, the nursing journals have a lot of new, different ideas, so I think we're referring to those. When you do a literature search on clinical education, nursing comes up a lot. Athletic training comes up a lot. Even though their internship's different, their on-the-field internship is very active. Them in the clinical rehab is not as much, but they have a lot of published articles. So I kind of refer to other disciplines. Stephanie mentioned veterinarian, but medicine. So we do use those models, or at least look at those models, and they give you different viewpoints, so we can incorporate into PT. No. There's not a specific text that I think is really current or state of the art, kind of its current practice that like be one I would say go buy that book or something.
Now, follow up that, do you foresee that changing? Do you feel that?
I do. Yeah, I think because there's a push now at the foundation, the Academy of Physical Therapy Education, of research. There's a big push, and I think that's going to fit that concept of we need to publish articles on education and clinical education. So I think that will change it.
Yeah, no, it's great. And I think it's been a really enlightening discussion, just learning about all these different things, especially to get that perspective of kind of all these avenues. And we like to usually wrap by asking this final question to everyone.
Okay.
So the question is, if you could change one aspect of healthcare education, which aspect would it be, and how would you change it?
I think we need to come up with the sweet spot clinical experience. And with that, then hold true to that, make it consistent. Because administrators are asking me a lot of times, what is our outcome? We're taking these students, are they being employed by us? Because they look at sometimes that as an outcome. And when they start working, are they working day one? How long of an internship do we need beyond their schooling? So if we can find that sweet spot, I guess that would be the thing. How do we do that? We need to start studying when an 8-week or 12-week or 16-week clinical, which is getting us that outcome that makes the students confident when they graduate. And I think we need to find that.
Yeah.
And that's going to take that brain of openness, if you will, to make that happen.
Yeah, because that sounds even like such, I mean, when you're saying that, I'm just thinking of all these other things that can influence those results. Location, cost, type of program.
Exactly.
And all those things, it's like, how do we account for all that? You know,
it's enormous, yeah.
Well, Scott, we thank you so much for joining us today. I mean, I learned a lot about clinical education that I didn't know before, which is one of the reasons why we love doing these podcasts. So thank you very much for joining us. And if you have, where can we find you on social media, Scott, if somebody wants to get a hold of you, or on other online means?
Okay, well, I'm definitely on Twitter. During conferences, I tweet a little more. Sometimes I go through spells where I don't tweet. I have a little underscore, so it's Scott OH, I think _PT or something weird. I don't know why I did it that way. But you can find me, I think, Scott Euype, the last name Euype. I don't know if you guys spell that. But you can find me through my work email, UPS@ccf.org. That's it. Yeah, thank you. It's _OHPT.
And if any of our listeners are kind of curious, we have all those links to everything that he kind of just mentioned posted in the show notes. If you're interested, just feel free to check them out, and then you can go from there. But again, Scott, thank you so much for the time and everything, and for your service.
Yes, thank you for your service to the APTA. And hopefully we'll see you serving again sometime in some capacity.
Right. Thank you, guys.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available in our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.